We are back. Apologies, everyone, especially to Bardia. You were mid-sentence.
No worries. Thank you.
Let me just make sure they give us the permissions. You should have share permissions now. And we'll just give everyone a few seconds. We had 15, so just wait till people are able to log back in.
Can you see my slides now?
Yep, no problem. Okay, Bardia, if you'd like to begin again, apologies for the disruption.
That's fine. Thank you. So similar to the healthy wrist, I'm showing the replaced wrist results. I think, yeah, I thought about this slide, I forgot. But yeah, so the important part here is our hypothesis was that the center of rotation is about the same place as the center of curvatures, which we verified that hypothesis in this experiment. So the data that I showed, it can help us to understand the joint better in pure movements. But we want to know how center of rotation moves when there is a combination of pure movements. So the question is basically how the center of rotation moves when there is a combination of motions and, for example, in circumduction. Right now, we only look at flexion, extension, and radial ulnar deviation. So the 3D movements of an axis of rotation has 3 special parameters. And we want to see how it moves as the wrist moves. So basically, we needed a 4-dimensional plot. And to make this easier to interpret, we defined a projected center of rotation parameter, which describes the center of rotation movement in only 1 dimension. Axis of rotation here on the figure, as you see on the right, is the red line somewhere in the space. And we chose the mid-axis of capitate as our reference line and to describe the up and down shift of the center of rotation. We find a point on this line that has the shortest distance from the axis of rotation, and this point is unique, which is shown here on the as the yellow circle. And we call this the projected center of rotation. Right now, what I need to look at is the location of this yellow circle from the reference point, which is the orange point shown here, the most distal point on the capitate. And we can look at the blue line or the shortest distance and the elevation angles to create a complete picture of how axis of rotation moves in the space. So in this figure, I'm showing the proximal distal shift of the projected center of rotation in the y-axis as a function of the wrist motion on the x-axis. The left figure or panel is our healthy wrist results, and the right panel shows the replaced wrist or the TW results. And the center of rotation shifted in a sinusoidal pattern, and the solid black line with the confidence interval as the shaded regions are shown here. And the healthy wrist's center of rotation traveled approximately 7 millimeters, while the replaced wrist center of rotation traveled about 2.5 times more than that, about 17 millimeters. And pink dashed lines here are showing the location of the center of curvatures, which we saw in the previous slide. And based on these mathematical models and averaging the elevation angles, I evaluated the overall pattern of screw axis orientation and location at 4 anatomical and 4 coupled wrist motion for a typical healthy wrist in the radial view on the left panel and the volar view on the right panel. In healthy wrists, rotation axis for pure flexion extension and radial ulnar deviation were orthogonal and consistent with the motion. And for the dart throwers movement, which is radial extension to ulnar flexion, and anti-dart throwers, which is radial flexion to ulnar extension, they followed the same pattern for healthy wrist joints. For the replaced wrist, similar to the healthy wrist, rotation axis for pure flexion extension and radial ulnar deviation were orthogonal and consistent with the movement. But as you see, radial flexion and ulnar flexion, they were not compatible with the healthy wrist behavior. What this means is that the coupled motions during the flexion of the implant, they don't follow the behavior of the healthy wrist. And in both cases of flexion, they are slightly pronated, which might cause problem at the end. So in this section, we found that the center of rotation of total wrist arthroplasty cohort is located approximately at the centers of curvatures of the articulating surface. But we saw that this shift of center of rotation is about 2.5 times more than a healthy wrist during functional tasks. This behavior of the center of rotation movement shows the discrepancy between the healthy and TWA kinematics and the relative high complication rates of the current TWA designs that we see could be associated with these abnormal forces that they probably are because of the mismatch reported between the replace and wrists behavior in this study. And our finding for the healthy wrist center of rotation for the pure movements were similar to the previous literature reported on the in vitro experiment. And both the methods that we developed in this work and the findings were novel. And we hope that the other joint replacement designs start using the projected center of rotation to evaluate the implant behavior. The other important factor in the joint replacements is, in the joint replacement realm, is the alignment of the implant. And clinical consequences of alignment errors in total knee replacements have led to the accurate evaluation of the surgical techniques. For the knee, there are patient-specific techniques or systematic techniques that look at the hip or ankle angle, and then they try to replace the implant in a way that maintains these orientations. Similarly, for the hip joint and the ball and socket design that it has, but for the wrist replacement, the guidelines are not providing any standard, and the alignment is not measured in any of the literature. So my main goal here was to assess the alignment of total wrist arthroplasty. And we wanted to define some measures for it and see if the malalignment is associated with a range of motion or clinical outcomes. So we used two common X-ray images of the wrist. On the right, you see the posterior anterior view, and on the left, you see the lateral view of the wrist from the sides. And the blue lines are showing the alignment of the implant, and we measure them objectively based on the stem orientation or the peg of the carpal component. And similarly, the red lines are for the bones, and the angle between those is showing the orientation or the alignment of the implant. We also measure the alignment in 3 dimensions, computationally and automatically based on the relative alignment of the coordinate systems. The relative orientation of the individual implant components to the bones was calculated using the scalar product of the x-axis and y-axis for radial and volar tilt of the implants. First, we validated our radiographic measurements using the 3D models. And we saw that the radiographic measures have a limit of agreement of less than 3 degrees and 3 millimeters, except for the measures of carpal component in the lateral view, which are shown in orange here. And the lateral view of the wrist in X-ray is heavily occluded because metacarpals overlap with each other, and it is hard to find the best orientation for the third metacarpal. We also measured this 3 times. So we had 2 raters, and every rater measured this twice. And we saw intra-rater and inter-rater agreement of more than 0.9, which shows the consistency of these measurements, measurement technique. In our small cohort, we saw that the wrist flexion extension and radial ulnar deviation were correlated with the volar dorsal tilt of the radial component, and they showed a range of motion increase of 4 degree or 2 degree per degree increase in volar tilt. It is worth noting that the radius bone, naturally it has a volar tilt, but the freedom arthroplasty design for the radial component, it doesn't account for that. It has 0 degree volar tilt. So this basically creates a bias that favors the wrist extension, and it's confirmed by our analysis that we saw that the extension is about twice than flexion in our experiment. Similar to the volar tilt, we saw that the volar offset is associated with the range of motion increase, and the volar offset and volar tilt of the implant were slightly correlated too. So determining which one of these factors had more role in final range of motion increase, it wasn't possible in our study because of our sample size. So we demonstrated a high degree of accuracy between the manual measurements of the radiographic alignment, and we measured them, validated them using a 3D-dimensional measurement system too. And we only validated our technique for freedom arthroplasty, but we believe they are applicable to other designs because they are sharing similar design features. And we also identified a potential association between the increased wrist range of motion and increased volar tilt and offset of the radial component, which shows the alignment parameters are important and they might influence the clinical outcomes later on. And although our cohort was small and we did not have access to the preoperative information to infer a broad case for the volar tilt, the potential association suggests that there might be value to larger cohort studies with more focus on the alignment of the implants for future studies. Lastly, so the hip and knee joint replacements have been studied at the contact level. For the knee, these studies have led to designing joint replacements that mimic the rollback of the knee, for example. For the hip, the studies found the problem is impingement, and impingement happens when something prevents the smooth motion of the joint. For example, here for the hip, you see it's trying to go down, but it can't because of the inherent feature in the design, so it creates impingement. And that creates an abnormal location for contact stress, which might yield to polyethylene debris generation and osteolytic cascade, which ends up in failure and high complication rate for the implant. If this is happening for the total wrist arthroplasty, we need to know where are these spots and modify the design and have a plan for it, basically. So my last aim was to analyze the contact pattern, and finite element models have shown the ellipsoidal design total wrist arthroplasty has high stress levels on the ulnar aspect of the radial component. And they have also shown they are more likely to achieve higher stability and they have a more consistent contact area compared to other designs. That's why the designs are mostly these days are ellipsoidal joint. But this is unknown if it changed or not in vivo movement. So we hypothesized, assuming the component congruency, that the center of contact is located at the geometric center of the carpal component and radial components, and it moves along the arc of curvature that they have. So we calculated the contact patterns between the carpal component and radial component using the wrist kinematics and the component-specific distance fields. Distance fields are calculated for each closed 3D surface as a volumetric array of signed distance values from the surface. And using these proximity values, of the surface for polyethylene cap and the radial component, we calculate the distance between the components. Basically, we use the kinematic data, we move the implant around and see what's the proximity between these two components. So to calculate the center of contact, we weight each one of these proximity values based on the threshold parameter that we have and the proximity value. This way, those points that they are closer to the surface have a higher impact in calculating the center of contact. Previous studies have shown this way is more robust and follows a more continuous pattern for the center of contact. We also calculated the sensitivity of our method, which is 0.7 millimeter, but due to time, I can't show all of the results for this aim. So we only look at just few of them. So at the neutral posture, we saw that the center of contact was not located at the geometric center, and it was significantly located radially and dorsally. Similarly, the center of contact was significantly located a little bit on the ulnar side and dorsal side for the radial component. Using mixed models to create a predictive model for the center of contact, we looked at the flexion extension angles and the position of the contact on both components. Here, the bigger circles show the actual model predicted center of contact, and the small circles are confidence intervals. So throughout wrist flexion extension, the average center of contact was located radial to the geometric center for the carpal component, and it was located ulnar to the geometric center for the radial component. And based on our analysis, the center of contact moves in opposite direction on the radial component and carpal component. This opposing rotational and translational behavior might result in impingement and restriction of range of motion at certain wrist postures, for example, the full flexion position. And moreover, the understanding the nature of these joints articulation could improve and be used for validating the future computational models. Similar to flexion extension, if we use the same technique to evaluate the radial ulnar deviation movement and the center of contact. And as you see, the movement on the radial component is minimal, and the pattern in general has a narrower confidence interval, which shows for radial ulnar deviation, the movement on radial component is minimal and it's mostly contact at one point. So I didn't show you here, but we computed the sensitivity of a BVR system in estimating the contact pattern, which can be used for all our biplane video radiography experiments. And here we hypothesize that the center of contact moves along the principal axis of curvatures, but our assessment showed that the center of contact is mostly located on the radial side of the surface for the carpal component and the ulnar side of the surface for the radial component, which is a mismatch from what we expect to happen in vitro and in mechanical testing. So our finding can inform future design considerations for total wrist arthroplasty. It can also help us to determine protocols for wear and stress testing of the total wrist arthroplasty in the laboratory. There were some limitations in our study. We only studied 6 subjects for our TWA cohort, although we saw a high consistency for our regression analysis. And we accounted for subject variances in our generalized linear models. But enrolling more patients can help us to have a higher power in our conclusions for this study. And also, we didn't know, because of our sample size, we didn't evaluate how the alignment of the implants affect the center of rotation location. And detecting this variation wasn't possible for us because we only had 6 subjects. So some key points here. First, we found out that the center of rotation of the total wrist arthroplasty moves about twice that of a wrist. And we also provided a continuous accurate representation of the center of rotation that can be helpful in designing future implants, which is actually something we are doing right now in the lab to design an implant using this data. We also defined radiographic parameters that can be used to measure the alignment of components reliably. And we also showed that these alignment measures, particularly the volar tilt of the radial component, can potentially affect the range of motion outcomes. We also evaluated the contact pattern of the components, and the center of contact was mostly located in a place that we did not expect. And we also determined the potential regions of impingement or limiting factors for the range of motion. There are multiple areas of research that we can use this data for, or we can design studies based on. So first, we can test more implant designs and with larger cohorts to compare the designs and find the optimal solution. And using prospective studies with both pre and post-operation data, it can help us to understand how these implants lead to high complication rates. And we can use robotic simulation to understand the effects of, for example, alignment easily and non-invasively. And the robotic simulation can be derived based on the data that we captured in vivo. And also instrumented total wrist arthroplasty designs, those the devices that have sensors underneath them can help us to understand the load and forces of the implant and the load distribution at the joint level to improve them. So let me briefly talk about two of the projects that are ongoing in our lab that and I'm interested in working on. So one of them is triplane video radiography. You see the experimental setup here, capturing the motion of carpal bones using 2 video radiographs is error prone. So we decided to strengthen the system, and we are using 3 X-ray sources basically. Here you see the one pilot wrist that we studied in various postures, and we tracked lunate, scaphoid, and capitate in it. And I'm actually collaborating with Natalia on this one, and we are using this kinematic data as boundary conditions for her finite element model. And another ongoing project in our lab is to study the shoulder biomechanics, which is a recent area of research interest for me. There are many metrics like antiversion or glenoid type that are measured before surgery, and they help surgeons for surgical planning before total shoulder arthroplasty. But these metrics are measured when the patient is in supine or laying down position. But the literature of the morphology of the joint is based on X-ray images that are captured in a standing posture. So currently I'm planning to use our biplane video radiography system to capture the shoulder in standing posture and evaluate the differences between these metrics when captured or when they are captured standing versus when they're captured in supine position. At last but not least, I want to thank all of my collaborators in the past few years, and I'm indebted to all of my collaborators, students in the lab, and everyone's thoughtful and helpful comments that you see their names here, and specifically my advisor, Dr. Trey Crisco. Thank you so much for your time and attention. I would be happy to answer questions.
Ardia, thank you very much for your presentation, and apologies again for some of the technical issues we had with Zoom. I don't think it disturbed it too much. Just a bit.
Thank you so much for having me.
Well, we can open it up for questions, but I've got some carried over from the previous session into the chat line. Looking back at earlier in your presentation, you were mentioning the database for which you created a user interface so that people could interact with. Looking at the user interface, I saw that there were different cohorts in the bottom left. Could you describe some of the different cohorts you have available in your data set?
Yep. Let me share my screen for that slide. I'll find it. Okay. Yeah, so we have 4 cohorts. So basically in our lab, in the last 20 years, we had different funding sources. And can you see my screen now?
Yep, can see it.
Yeah, so we had four different cohorts in our lab. So we had 4 different experiments running in our lab. And So some of them are, we asked our patient subjects, healthy subjects, to come to the lab, and they moved the wrist in. So these were static postures. So we asked the subjects to hold the wrist in full extension. We measured it with goniometer. For example, this was one of the postures. The other one was neutral, and the other one was full flexion, for example. And we had 5 or 6 different variations. That's the incremental orthogonal group here. For the combined group, we asked them to perform circumduction, but this was still static. So they moved their wrist with goniometer. We measured 30-degree flexion, 20-degree ulnar deviation, and we captured their image in that posture. We also had another study that they held a hammer, and we told them to keep your wrist in the full. We designed actually a toolbox for it, that hold your wrist in the full extension while you are hammering and simulate the path. And the other study was a study that the experiment that we did for first carpometacarpal, or the thumb joint, which is basically one of the tasks here is showing, I'm showing, is the jar grasp. We had a jar and we asked the subject, okay, hold this. And another one was, for example, doing the holding the jar from the top. And these were the various pictures, kind of the tasks that we had for the patients.
And can I ask also, you meant there was probably a range of ages and possibly the presence or absence of pathologies. So what we found is working with cadavers, generally you get older people, you don't get many young cadavers. And one of the consequences of that is, if you have an old wrist, it's usually partially degenerated anyways, at least from a ligament perspective.
Yeah. So all of our subjects, they were screened, so they were all healthy. And we had, I think, probably, I have the number somewhere, but we had both young and old, and we categorized them based on their, so I think our threshold for age was 45 years old. And I think we had about 45 or something young people, and the rest of it were old, 70 or something. And they were kind of, we had both genders, to male and female. So it was a kind of wide variety of subjects, but they were all healthy and they were pre-screened.
Okay, well, thank you. And Tash, she had a question about how does the tissue classifier, you mentioned it as a way to, I think, interpolate between these static positions. Can you give us a bit more information on that?
Yeah, so basically the way it works is, so for example, for one of the study, we captured the CT scans for one subject, we captured the wrist position in 13 different postures. One of them is the neutral posture, neutral task, and there are 12 other tasks like jar grasp. But because it's a really time-consuming task to segment every CT scan, what we do is we just segment the first one, and using the method that we call it the tissue classified registration method, we find the transformation between those. And how this works is, so in computer science, there is a algorithm called sign distance function, which basically you can find, so you can say, okay, this is my bone, for example, here, this is my bone, this purple color, and everything inside is a positive number and everything outside is a negative number. So it creates a 3D volume of numbers of negative and positive. And what we basically do is, so this can be calculated automatically. So what we do is, based on, because we have the neutral posture, we can find the best transformation between this 3D matrix and another 3D matrix. And yeah, that's how basically it works. But it's a little bit more complicated than that, and the mathematical equations are.
But it hinges on essentially the volume being preserved and the tissues being more or less rigid. I don't know if there's a shape component or if it's just pure volume.
It's pure volume, but exactly, it's completely depend on if the bone is not changing, the shape is preserved.
Okay, cool.
And it's a process that, so we use high performance computing systems, and it takes 5 hours for computers to run it. Yeah, it's a long, for all of the 12 tasks.
So it's like some brutal numerical method. Yeah,
Exactly.
try
It's
everything.
brute force methods to find the transformation.
Okay, so our next one, I had another question in here. This was, I think, also from Natalia. Does the algorithm allow automatically to place an implant inside your anatomical model? So if you had a CAD that was not imaged, so you had a healthy wrist and you wanted to simulate the implant, could you merge these in any way?
That's a really good question. No, so right now, no, our algorithm doesn't do that. So the problem is the code is pretty old and it's on one of our computer science collaborators. So we don't have access to that algorithm to play with it and try different things. But no, that's something that's really interesting. So I was thinking about, for example, putting the implants, kind of simulating the surgery, the similar method, but that method has to be, it's manual. Yeah, we don't have a good way to do that automatically.
Oh, that's okay, cool. And I've just been reading the chat line and answering questions. So if anyone else has questions who are on the line, feel free to jump in. This last one was more related to some of your findings about the mean helical axis for different motions. When looking at some of the results, it appeared that there were a range of different movements or helical axes based on the type of movement you were doing. Is it possible for an implant to accommodate these very different positions and orientations of those helical axes within the articulations? Or is it more about trying to find a compromise between them that works sort of okay?
Yeah, so that's a really good question. So there are ways. So I want to say there are ways that the implant can accommodate the, for example, the healthy behavior that I'm showing here. The implant can do it, but the problem with all of this is we have to put them back in the patient and see if that's kind of, that it stays the same when the patient does it. So for example, based on just this calculation here, I can say, okay, if I just move so the pink line here shows the center of curvature for the larger kind of ellipsoid, basically. So it's this curvature. So what I can say is, okay, if I just make this narrower, this is going to come down. So I can simulate a pattern that is more like the healthy wrist. And so it can, basically, if we change the design, it might be able to mimic the healthy wrist. But the problem is we don't know if that's what we should do or not, because we have to put it back in the patient and see if it works. Basically, so this design is trying to simulate the radiocarpal joint. And it depends if we want to simulate the radiocarpal joint or we want to simulate something that the capitate does, the midcarpal joint.
Well, I suppose with replacements, you may not be able to accommodate all the movements, but possibly. I would suppose radiocarpal motion would be the primary, and then maybe there would be a secondary. I don't know.
Yeah, that's a good point. Yeah, that's something that we can definitely, we can probably do that. Yeah.
Okay, so I'm just a bit conscious of time. Is there anyone else on the line who wanted to mention anything? I know definitely the triplanar videography is really exciting stuff. We've got Jayshni on the line, so you know, for foot imaging, that's obviously a hot topic. Is anyone else want to chime in?
Yeah, using the triplane for the foot is a little bit challenging because yeah, it's kind of, the area is restricted, so patients cannot walk a little bit.
Yeah,
Yeah.
and it's a more contrived motion.
Hey Vadia, I have a question. I was wondering if you could use your otoscope for 4D CTs.
That's a really good question. So that's something actually, so I didn't talk about it, but it's a grant that we are trying to write in our lab. We actually we are collaborating with Mike Rainbow And yeah, we are trying to use basically we are trying to create synthetic radiographs from the 4D CT and track them. Instead of segmenting them, we want to register them basically.
Yeah.
That's something that we are working on, and yeah, I don't have the slides, but yeah, it's something we are collaborating with Slicer team and yeah, other universities to make that work.
Okay, so it's in the pipeline.
Yeah, it's hopefully soon. Yeah.
Okay. Because yeah, not everybody has access to the beautiful biplane and triplane system that you guys have, right? So we got to find another way.
That's something actually I'm really interested in, kind of making otoscoper work with 3D segments, 3D image volumes basically, or for the CT.
Okay, cool. Because yeah, sounds good.
Yeah, well, 4D CT is more accessible, so that would probably help its uptake and things like that.
Yeah.
All right, well, just in the interest of time and due to Zoom's proclivities, maybe we'll close it here.
David, David, the last question is from Alistair. It would be good if more people ask using this opportunity. Yeah.
So Alistair, who's a mechatronic engineer with our group and handling a lot of the robotic stuff, was just asking a question about a very specific question about one of your slides, slide 45.
Can you hear me? Sorry, the previous slide, 44.
46.
So on the right image, on the right graph, you can see at the end, it sort of splits off into two groups. The lower and higher constrains your shift on the mid-axis. Can you comment about that? I'm not sure if you did. Yeah.
So you mean this part and a little bit lower, or?
Directly underneath along the deviation line, you can see that there's clearly two different groups.
Oh, okay.
You know what I mean?
You mean this kind of sinusoidal
pattern? Yeah.
So this is basically, so we had 6 subjects and we are scaling all of these too, but this is, so I don't have the subject specific color codes, but this is probably different subjects moving the wrist. And so our scaling method is using their capitate volume, but the capitate is resected. So it's not the most stable way to scale them, but it captures their behavior, which is mostly what we're concerned about.
Okay. Do these results? Do you use these this center of rotation for other results later on that are derived from it?
Yeah. So the one that we use the average ones, and based on the average model, we create the actual pattern of behavior for the screw axis. Yeah,
and then you use that for the center of contact, or the
no, so we don't use this contact. No.
Okay. Yeah. Sorry, I just cleared that up. Yeah. Yeah, that was my question. Thank you very much.
All right, so I think we're running out of time again, but Bardia, hopefully this will be only I know you're collaborating closely with Tash and hopefully possibly with Jay as well. So look forward to continued collaborations and an opportunity when COVID allows for us maybe to come over to the East Coast and so on and to catch up.
Yep.
So awesome. That was a really great presentation. Thanks a lot.
Thank you so much for having me. Hope you have a great rest of the day.
Same. Thank you. Bye.